Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I am Odunsi, the founder of Overcome, and today we are joined by a very special and honored guest, Dr. Kunle Odunsi. Dr. Odunsi is a global expert in immunotherapy and vaccine therapy for cancer and is the director of the University of Chicago Medicine Comprehensive Cancer Center. He is a globally recognized physician scientist with a deep knowledge of discovery and innovation in oncology. As our advisory board member, it is our absolute honor to welcome Dr. Odunsi to this episode of Connect Over Coffee to chat about all things immunotherapy in ovarian cancer. So grab your favorite coffee or beverage. I have mine, although it's almost finished. And let's talk to Dr. Odunsi about immunotherapy in ovarian cancer. And if you have any questions as we go along, please type in the comment sections below and we will get it addressed post the discussion. And as I always say, please share all this insightful information Dr. Odunsi is about to share with us today globally with anyone who may benefit. So with that, a huge welcome to you, or welcome back to you, Dr. Odunsi, to this episode of Connect Over Coffee. Always such an honor to have you with us.
I'm very pleased to be here.
Thank you. So several questions, as I always do. And so I was looking back to the fantastic discussion we had back in 2021. When you were here on this as a guest for this show, that you talked about a lot of things in immunotherapy happening then in 2021. So tell us about the three most important advances in immunotherapy that has happened since 2021, since the last time we chatted.
Yeah. Well, first of all, thank you again for inviting me to this program. It's always a pleasure to be here and to try and answer some of these questions to the best of my ability. So immunotherapy has continued to be a major area that is making a tremendous impact on cancer patients across the globe. These are patients with all types of cancers, whether they have liquid tumors, blood cancers, or solid tumors such as ovarian cancers and other types of cancers. So one of the remarkable progress over the last few years has been in the area of cellular therapies. In fact, there was a recent FDA approval for the first time of a form of cell therapy that is called TIL therapy. TIL stands for, TIL, TILs stands for tumor infiltrating lymphocytes, which was approved for the treatment of patients with metastatic melanomas. So basically what this treatment involves is to take a patient's tumor and remove the T cells, the immune cells within the tumor, and grow them up into large numbers and give them back to the patients. It's been a very long road for this kind of therapy. I call it like first generational or type of therapies that we're going to see in this area, but it's a good start. So TIL therapy is one remarkable progress. The approval by the FDA is one remarkable progress in immunotherapy over the last few years. The other areas of progress include additional strategies to engineer T cells. Again, as I've said on this forum before, anytime you give a treatment anytime you try and treat cancer, the cancer always fights back. There tends to be a counterattack. And so how can we engineer our T cells, our immune cells that we give in cellular therapy in order to resist counterattack by the tumor cells? And so there's a lot of work ongoing in that area as well. And finally, again, I'm still focused on cell therapy. You can see, that I'm very excited about this. Finally, one additional area that is emerging is to actually engineer the cells themselves to secrete other molecules. So you put in the T cell, okay? This is, again, depending on, we can get into details about the different kind of T cell therapies, but whatever the type of T cell therapy, you can further engineer the cell to become a living drug. In other words, as it goes into the tumor cell, it can begin to secrete certain substances or molecules that can further help to destroy the tumor target. So that's cell therapy in one block, major advances in the area of cell therapies, and I believe we're still scratching the surface. The second bucket is going to be in the area of what I describe of approaches to prepare the tumor environment and make it receptive to immunotherapy. In other words, you have the tumor environment, which we consider to be very hostile to immune cells. Yeah. Because don't forget, our immune system is constantly trying to destroy the tumor. Yeah. So what we see when tumor develops is actually escape from immune attack. So can we reprogram the tumor environment and make it more suitable for immune cells to live and survive? So one approach that is gaining traction is the use of what are called oncolytic viruses. These are viruses that are specially designed to selectively destroy tumor cells and spare normal tissues. So you can imagine, you can drop them directly into the abdomen, into the peritoneal cavity for ovarian cancer. And in that way, when you do that, not only are you destroying the tumor cells, but you engender an immune response because the virus provides a danger signal to the immune system. And therefore, you are generating immune responses, you are destroying the tumor cells, and now we can engineer the virus also to deliver additional drugs, additional compounds within the local tumor environment. So that's a second strategy. The majority of these are still in clinical trials, but they are very promising. And then the third area that has become very important the last couple of years is the area of antibody drug conjugates, where you can pair antibodies with drugs, and also bispecific antibodies, essentially antibody-based approaches, either pairing antibodies with drugs or pairing antibodies with a strategy with another antibody, whereby the second antibody can essentially pull in immune cells into the tumor. So that these are some of the latest developments. Again, the majority of these are still in clinical development, clinical trials, but these are very promising strategies that I fully expect will mature in the next few years and give even better hope for our patients with ovarian cancer.
This is also exciting. Thank you for sharing all these, the top 3 advances happening. So just, I was thinking as you were talking, in terms of success rates, I know that this is in clinical trials, so the data is not read out yet, but in general, what is the success rate that you all are anticipating out of these trials?
Yeah, let me try and place things in context a little bit with regards to success rates of what we consider immunotherapy in general for ovarian cancers. Yeah. Maybe we should take a step back and define what is immunotherapy. Any strategy where you're using the immune system to treat cancer is immunotherapy. Okay. The most popular are the immune checkpoint inhibitors, okay, such as Keytruda, Opdivo, all those types of drugs that block immune checkpoints. So those are the most popular. And in general, most people refer to that as immunotherapy. Okay. But immunotherapy is more than that. For example, I already spoke about cell therapies. That's a form of immunotherapy. I also talked about oncolytic viruses. That's a form of immunotherapy. The bispecific antibodies, that's another form of immunotherapy. So there are multiple forms of immunotherapy. But in general, what you're going to hear is that immunotherapy doesn't work effectively in ovarian cancer.
Yeah.
Most people, when they make that statement, are actually talking about the immune checkpoint inhibitors. So the success rate for immune checkpoint inhibitors have been disappointing. And I think we kind of now understand the biology behind why they have not been as successful in ovarian compared with other cancers. And our group and others are working on strategies to overcome those limitations. And maybe we'll get into potential combination therapies and so on and so forth. But in terms of cell therapies, we fully expect that these are going to make a tremendous impact. And it may well be that we're going to need to combine the cell therapies that we describe with immune checkpoint inhibitors, or combine immune checkpoint inhibitors with the oncolytic viruses. So what we are seeing in many of our preclinical studies is not additive effect, but synergistic effect, where the whole is greater than the sum of the parts.
Yeah.
That's what we are seeing. So we're very optimistic that over the next few years, as we continue to develop some of these novel cellular approaches, and then we can go back and combine with immune checkpoint inhibitors, we're really going to see tremendous progress in the field.
Wonderful, thank you. So you talked about, different kinds of immunotherapies, right? So that is very important distinction. Now, there are also different kinds of ovarian cancers, right? The ovarian cancer is not one. So tell us about which types of ovarian cancer respond better than the others to immunotherapy, and why, and what should our overcomers know and ask of their healthcare providers based on the type of the ovarian cancer that they have been diagnosed with?
Yeah, that's a great question. So again, let's keep immunotherapy fairly simple by focusing on immune checkpoint inhibitors right now, and then if I need to speak to other types, I will bring them up.
Yeah.
So for immune checkpoint inhibitor immunotherapy, there's a certain subset of patients that tend to respond, whether you have ovarian cancer or lung cancer or melanoma. These are patients where you have high tumor mutation burden, for example. So it's important for patients to make sure that the tumors get tested for TMB, tumor mutation burden. Typically, that is now almost standard, where patients' tumors are tested for their molecular profile, and there are different ways of doing this. So tumor mutation burden in high patients potentially will respond very well to immunotherapy. Patients who have evidence of good pre-existing immune response. In other words, if you look at the tumor, it has high numbers of immune cells, especially T cells, present within the tumor. Those patients are more likely to respond. Again, this is regardless of the subtype of ovarian cancer. But getting back to your question, is there a subtype that tends to respond better?
Yeah.
In general, we feel that clear cell carcinomas tend to respond better than high-grade serous and other types. But the molecular drivers of responsiveness is related to those features such as the tumor mutation burden, as well as the presence or absence of high frequencies of T cells within the tumor in the first place. And then there are other molecular drivers, so there are some signatures that have now been defined that will predict that these treatments may work better in a subset of patients. But based on the histologic classification, clear cell cancers clearly appear to respond better than other types of ovarian cancers.
That's good to know. Thank you, Dr. Odunsi. So you have talked about many important things. And also you mentioned the combination therapies, right? So whether it be the combination therapies or the antibody therapies that you talked about and the checkpoint that you also talked about. So if you had to summarize the different ways to use the immune system to treat the ovarian cancer or any other cancer, would you add any more to what we already know about these things, or would you add more additional aspects to it?
Absolutely. So let me start by just stating a general principle. Okay, we have the soil, which is the cancer itself. So we need to reprogram the tumor microenvironment. So that's step number one. If you ask me what is my dream, what is my vision, to tackle ovarian cancer with immunotherapy, number one is to turn the environment. I mean, some people use terminology such as cold and hot, and those are okay. But really, what you're trying to do is to reduce all of those barriers to immunotherapy. Because number one, you need to generate immune cells, T cells, that are efficient, that can efficiently destroy tumor targets. Number two, those T cells have to travel to the tumor.
Mhm.
So there could be barriers to trafficking,
Right.
ability to penetrate and enter into the tumor. Okay, so we can engineer cells to be able to traffic better. So that's, again, some of the hopefully future generation strategies. So you need to generate sufficient numbers. They need to be able to travel efficiently.
Yeah.
And then when they arrive, they need to be able to stay and fight the fight, right? They need to resist counterattack. So therefore, the very first step, in my view, is for us to find strategies to reprogram that environment, make it conducive, make it so that it can overcome all of those factors. There are a lot of other factors. There are some bad chemicals that are produced by the tumor, by ovarian cancer. Okay, some of them are called cytokines. One example is a cytokine called TGF-beta, for example. It tends to handicap immune cells, T cells, when they get to the tumor microenvironment. And then there are some bad cells, bad actors that also constitute part of that environment that tend to suppress the good immune cells. So strategies to counteract all of these things by preparing the soil. We gave the example of oncolytic viruses, for example, where you can further even engineer the virus to produce substances that can simultaneously target many of those barriers. Okay, so you soften the cell, and then you come in with either an immune checkpoint inhibitor or a cellular therapy approach. So the principles are to make sure you prepare the tumor environment and then give the form of immunotherapy that is appropriate, whether it's immune checkpoint inhibitor, whether it's a form of cell therapy. So that's what I envision is going to happen in the next few years.
Yeah, so just if I understand you correctly, I mean, the groundwork is as important as actually going into and actually trying to, defeat the cancer cells. So it's almost like you have to prepare the ground for a battle before you go into battle, right?
Absolutely.
Yeah.
Just like our military, they do that all the time, right?
Right. Exactly.
Yeah.
So you pioneered the development of antigen-specific vaccine therapy. Can you tell us more about that?
Yeah. So that's a great question. So several years ago, we started, actually, this was when I started my lab. We asked a question about, because up until that time, the question of whether the immune system can actually recognize cancer was not very well, was still a little bit controversial. But it became very clear, I think around about year 2000, late 90s, that yes, the answer is yes, the immune system can recognize cancer. These were some elegant studies led by Bob Schreiber at WashU, along with Lloyd Old and others, indicating that yes, the immune system, and in fact, Bob Schreiber came up with the concept of cancer immunoediting. So the next natural question for us, for the field, including us, was what are the targets of immune recognition in ovarian cancer? So we embarked on a very extensive search, and we narrowed down on a family of targets. Targets are molecules that are expressed on cancer, but not in other normal tissue that can be recognized by the immune system. So these are, so we narrowed down on a group of targets, antigens, that are normally not expressed in adult male tissues. They may be expressed during embryonic life, and then some of them are expressed in adult male testes, but not in other normal tissues. So we focused on this group, and we found that in ovarian cancer patients, these targets, these antigens are actually expressed at varying frequencies, some of them up to 40% of cancer patients, some of them higher, some of them lower. So this was a very important observation at the time. And then since we found these potential immunogenic targets, can we develop strategies to generate immune responses against these targets? So we picked one of them that appeared to be the most immunogenic. This is called NY-ESO1. That's the name of that antigen target. And we began to construct vaccines against NY-ESO1 in ovarian cancer patients. So the first proof of principle is, can we generate immune responses? We showed the answer to be yes. What kind of immune responses can we generate? Okay, because if you look at the immune system, the cells of the immune system are subspecialized. For example, if you consider T cells, there are so many subsets of T cells that specialize in doing different things. Yeah. There are CD8 T cells, there are CD4 T cells. One is a cytotoxic cell, it can directly kill tumor target. The other one is described as a helper cell that provides help to other cell types. So we wanted to generate a broad immune response that will generate helper cells, the cytotoxic cells, antibodies, where everything is integrated in order to destroy the tumor. And that's exactly what we found with NY-ESO1 vaccination. So our first clinical trial was very, can I say, elementary. Again, funding is always a consideration. Yes. We didn't have a lot of resources. Yeah. We made peptides. We gave something called Montanide. We injected patients. And lo and behold, we were seeing great immune responses, even with that very elementary, rudimentary approach. So then we began to improve on this as we began to gain more resources. So we conducted trials, for example, where we engineered NY-ESO1 into viruses. Again, this different from oncolytic viruses, yeah. And used the virus to vaccinate to vaccinate, some of our patients. And we found that we generated even higher, more robust immune responses that was integrated antibody, CD8 and CD4 T cells, all of the critical elements that you need to fight were generated. And then we began to test whether we can combine vaccines with other approaches, because by this point, we began to understand some of those barriers that I talked about, where even if you generate the best immune reaction with your vaccine, there are barriers, there are challenges to the T cells. They face significant obstacles. They are going into a hostile environment. So how can we try and overcome some of those barriers? So we began to design additional studies trying to overcome some of those barriers. The bottom line is, A, we were able to generate immune responses. B, we learned a lot about the nature of the immune responses, but more importantly, in terms of patient outcomes.
Yeah.
Many of these were patients who were in remission, who had completed their frontline therapy, or who had, at that time, there were no PAP inhibitors, completed their frontline therapy, or completed therapy for relapse disease, okay? Yeah. So those were the population of patients. And the clinical question was, can we extend remission?
Mm-hmm.
Can we prolong or totally prevent relapse of disease? And we were actually able to show this. But remember, we were doing very small phase 1, phase 2 trials. Yeah. These typically were funded, with grants. And so the trials were small, but we did note that we were able to extend remission rates. But the handicap that the tumor throws in the way of these cells was something that is very important. And over the years, what we've done is to focus on trying to overcome some of those challenges. So vaccine approaches, I think, are still viable. Yeah. Especially in prolonging remission rates. Mm-hmm. We need to test it in large randomized studies. We haven't done that yet. That needs to be tested. But some of the newer developments is that at that time, I explained how we focused on cancer testing, these antigens that are expressed only in the testes, but not in other normal tissues. And we focused on NY-ESO1. Over the years, because of advances in technology, where now we can sequence the entire human genome very quickly, over the years, it's become clear that there's another class of antigens that are potentially, many of them are tumor specific. These are called neoantigens. They are created by mutations of genes in the tumor. Because if you look at any cancer, we talked about the tumor mutation burden. So there's mutations that occur in genes within the cancer cell, and these can create targets. These mutations can create targets for immune recognition. So one can envision developing vaccines against these neoantigens based on the mutations. And there are clinical trials that are ongoing, testing that approach in ovarian as well as in other cancers. None of these have been approved yet by the FDA. Again, these are ongoing clinical trials.
These are so promising. Thank you so much for sharing, Dr. Odunsi. So on the vaccines, I'm understanding that those clinical trials are ongoing, but they're not recruiting any longer, right? For our overcomers to know.
For NY-ESO1, right now we are not recruiting because we are. First of all, we moved.
Yes.
I changed the institution recently, so we are still trying to to get some of those things going. But there are other centers in the country where vaccine approaches are ongoing. So I will encourage overcomers to look at those centers where they have vaccine approaches. Some of them are called dendritic cell vaccines. Some of them are called, some of them are the neoantigen vaccines. So I will encourage anyone who is interested to look up some of those other institutions. At the present time, we don't have an NYSO1 vaccine ongoing clinical trial. We're hoping to develop one in the near future.
Thank you. So as you were talking, I was thinking at the elemental level, right? So what you are doing, your exemplary work is trying to initiate, energize the immune system to be able to tackle the onslaught of ovarian cancer. Now, where patients have some immune compromised diseases, right? So they have their bodies, other than cancer, could be already in an inflammatory state with diabetes or other, immune related conditions. For those kinds of patients, talk to us a little more about, if the soil is already inflamed with other comorbidities, how do you progress with something as promising as this for those particular subset of patients?
Yeah, that's another great question. I think what is critical is going to be clinical judgment of the treating physician, sharing the decision with the patient, trying to understand the risk-benefit ratio.
Yeah.
So, for example, a patient who has pre-existing autoimmune disease, is that a patient you want to give an immune checkpoint inhibitor? So the question is going to be, what is the severity of the disease? What kind of treatment is the patient on right now for that disease?
Yeah.
So, for example, many times autoimmune thyroid disease is so very well managed that in general, it will not preclude the use of immune checkpoint inhibitors. So what kind of autoimmune disease is this that creates this inflammatory condition that you talked about?
Yeah.
So because immune checkpoint inhibitors, for example, in the process of activating the immune system, can activate immune reaction against normal tissue and cause autoimmune disease.
Yeah.
So some of the side effects of immune checkpoint inhibitors include, autoimmune thyroiditis, which affect the thyroid gland. It can affect actually almost any organ in the body. It can cause pneumonitis, hepatitis.
Yeah.
It can affect the adrenal gland, can cause nephritis, GI with diarrhea. So there are all these. So do you give a patient who already has pre-existing colitis an immune checkpoint inhibitor, which we know can cause autoimmune colitis? So all of this is on a case-by-case basis, depending on the clinical presentation, the severity of the autoimmune disease, how the patient is currently managing the autoimmune disease. So the short answer, it's not 100% exclusion. It has to be judged. However, I have to say, within the context of many clinical trials, typically those things are exclusion criteria. But in real world practice, there's a judgment that can be made.
That is fair. Thank you so much for that answer. So so you talked about lots of things happening in the field of immunotherapy. So we understand it's a complex field, and so lots of answers are not there yet. So tell us, in your opinion, what we do not know about immunotherapy in ovarian cancer yet. What is it that we don't know yet?
Well, the first thing that I have to say is is that, so maybe this is actually more for my colleagues, where people now say immunotherapy doesn't work in ovarian cancer. I think we should not give up.
Yes.
The fact that immune checkpoint inhibitors have not worked in at least 2 or maybe 3 or 4 large phase 3 trials, even when it, combined with chemotherapy, combined with bevacizumab, still did not work, doesn't mean we should give up on the use of immune checkpoint inhibitors. We need to figure out best to use it. That's number one. Number two, we need to figure out biomarkers. Who are those patients who are going to respond? There's still a small proportion of patients that respond very well without any other manipulation. Who are those patients? So we need to identify biomarkers that will allow us to identify those patients who are likely to benefit from immune checkpoint inhibitors and use it. Number three, what are the most appropriate combinations? So we should be thinking about the combinations, taking into account the principles that I highlighted, where you need to prepare the soil. If you just give immune checkpoint inhibitor without preparing the soil for the majority of patients, it may not give us the best outcomes. Number four is what we do not know right now is that cell therapies I think is going to have a tremendous place in the treatment of ovarian cancer patients. And there are ongoing studies, again, many of them general solid tumors. But actually, there was a paper, I think early last year or middle of last year, that already showed that ovarian cancer patients are responding. Again, these are small phase 1 clinical trials, maybe it's phase 1/2. Ovarian cancer patients appear to be responding to some form of cell therapy. One particular one is targeted at one of these family of antigens, just like NY-ESO-1, an antigen called MAGE-A4, where some of the responders, best responders in that clinical trial, were ovarian cancer patients. So there is promise, significant promise with cell therapies. And then we'll have to figure out how to either combine or sequence, because the more you add different approaches together at the same time, the more the potential for side effects. How do we minimize side effects? Do we need to sequence and give one thing first before the other? So those are all questions that we're going to need to address for ovarian cancer.
Thank you. And this is a good segue to my next question. I was going to ask you about the toxicities that can be involved in immunotherapy, and what should our overcomers be aware of in terms of side effects, quality of life, etc., when it comes to this kind of treatment. And how do you determine, again, for candidates for immunotherapy, at what point do you determine that this is best to discontinue based on the toxicities?
Yeah, so the toxicities, some of the toxicities of immune checkpoint inhibitors, we already kind of touched on.
Yeah.
And the most important toxicities to be aware of with immune checkpoint inhibitors are those autoimmune toxicity, which can affect almost any organ in the body, whether it's the lungs or liver or kidney or adrenal gland or GI. So it's very important to get treatment in a facility where the providers are familiar with the use of these agents. There are some monitoring that needs to happen during the treatment to stay ahead, to make sure, for example, a patient is not developing autoimmune thyroid disease that can be easily managed. So there are some measurements that one can be doing as you move along to either make the diagnosis early enough, and then consider the overall clinical picture of the patient. For patients that suffer significant toxicities, it may warrant total discontinuation of the drug. And we've had to do that for some of our patients where they're just not able to tolerate those drugs. Unfortunately, when that happens, then the potential to get back, especially on some clinical trials, the opportunities become limited because of those types of toxicities. Which is quite understandable, because there will be concern that if you try it again, even within the context of a clinical trial, that toxicity may even become exacerbated. So I think for the immune checkpoint inhibitors, the toxicities are clear. For cell therapies, at least at the present time, are typically given at institutions who have expertise in bone marrow transplant, stem cell transplant, where you have adequate support. One of the major side effects in cell therapies is something called cytokine release syndrome, where you've put in a lot of cells. And I mean, the simple way to explain it is that you have billions of immune cells, T cells, that are kind of hanging around trying to fight the good fight. Yeah. And they are producing different types of chemicals as part of the fight. And then, so the patients can become very sick, almost like very bad flu type situation. So that is called cytokine release syndrome. And again, that is something that you need to be in a facility where they understand. I think it's now totally manageable, yeah. But you need to be in a facility where they understand how to manage some of these side effects. For cell therapy, fortunately, most of the time it's a single shot. It's one treatment, and once you are done, it's like once, one and done. So even if a patient experiences those side effects and you manage it, it's for that one time. There are beginning to be cell therapies where you can, repeat administrations, but those are still very few and far between.
Thank you. So we are also hearing a lot about these drug factory implants, right? So, and the major funding that it received recently in advancing immunotherapy in ovarian cancer. And being in Houston, we are very involved with this Rice University initiative. I am an alum from Rice, so personally involved in this initiative. But I just generally wanted to know your expert opinion on this approach. What do you think about this approach, and how do you see it benefiting advanced stage ovarian cancer patients?
Yeah, so I think it's a very fascinating approach. Essentially, one simple way that I would put it is that it's almost like you have a you have a continuous ability that to receive a drug or a medication, and you can program it, you can switch it on and off, which is the good thing. I think the main advantage is the fact that you can deliver drugs locally into the tumor environment. Exactly. Especially for ovarian cancer, I think the ability to penetrate the tumor is very critical, which I think is a lot better. I mean, we saw this with IP chemotherapy. Yeah. And now with this drug factories, if you can imagine, if you put something in there that can deliver directly into the tumor. So I think it's a very promising approach. And some of the ones that I've seen that have been tested now include the use of factories that are making cytokines. Yeah. Some of these cytokines are these chemicals that can help T cells, immune cells, to survive and live longer. So there are factories now that have been made that can promote ability of immune cells to live longer. So I think we need to test them in clinical trials. There are clinical trials being, either they already started or they are being planned to test some of these concepts. But I think it could be particularly promising in the context of ovarian cancer.
Wonderful. Thank you for your expert guidance. So talking about all these, you've talked about many of these exciting advances, particularly when it comes to your lab right now. What are some of the most recent trials that you are running that our overcomers may it's open and they can sign up for, and what is your vision? And you talked about your vision earlier as well. And what are you most excited to come to work every day when you, as an immunotherapy expert? Tell us about that.
Wow, where do I start? Let me talk about something that is very, very close to maturing, where the clinical trial will open pretty soon. This is an oncolytic virus platform, where I think we already talked about oncolytic viruses. So this is an oncolytic virus platform where patients who have platinum-resistant ovarian cancer will be enrolled onto this trial. These will be patients who will be getting their standard of care liposomal doxorubicin. Then we would directly deliver oncolytic virus into the peritoneal cavity, using a catheter, almost like the IP chemo, using a catheter, deliver oncolytic virus. Now, this is a unique oncolytic virus because we have further engineered this virus to produce a chemical that will block many of the bad actors within the tumor microenvironment. The preclinical studies are very robust. It blocks many of the bad actors within the tumor microenvironment. It actually also normalizes the tumor vasculature, and that allows ability of immune cells to travel very well into the tumor. So the oncolytic virus with liposomal doxorubicin, and then on top of that, again, remember the principle of preparing the soil, then we add an immune checkpoint inhibitor on top of that. So we're very excited about that trial, which will be coming up in the next few months or so. We're in the process of finalizing the IND from the FDA, and hopefully we'll be able to start the trial in the next few months. So that's very exciting. But there are a number of other exciting things that are going on that we're really very excited about. One of the clinical trials that we did a few years ago opened our eyes to how the metabolic attributes of ovarian cancer cells can also affect the immune cells. So tumor metabolism, remember the tumor cells are very aggressive. They are trying to eat everything in the vicinity. Essentially, they starve the immune cells of amino acids, of glucose, and so on and so forth. But in the process of starving the immune cells, then they produce certain metabolites that are bad for immune cells. So we've identified some of those, and we're focused on trying to develop strategies to counteract the ability of tumor cells to make those bad metabolites. So again, that's something that's very exciting that we're working on. And then there are a number of other studies.
So we need to all follow you and your progress. And so for our overcomers that want to sign up on the clinical trials, need to stay tuned on when these trials are going to open. And they could go to your, in fact, Overcome we have a clinical trials database on our own website right now. So they can search for you when the trials are open and apply, basically.
Absolutely.
Thank you. So let's talk about beef and dairy, because you have done some work on that, it seems. So I was just reading this article on your work where you talk about this nutrient that you found in beef and dairy that enhances anti-tumor immunity by activating the immune pathway. So tell us about this fascinating study and how can this information be made actionable?
Yeah, this is a very fascinating story. The study is led by one of my colleagues, actually. I'm a collaborator on the study. And it's this whole notion of how metabolites, I just talked about metabolites
Yes.
a few moments ago,
Yeah.
can have dramatic impact on how immune cells are behaving within the tumor environment. So my colleague, Dr. Jin Chen, started off by looking at a library of nutrient-derived metabolites and ask the question, how do these metabolites affect immune response? The study started in vitro in a petri dish in the lab, and after looking at a large number of metabolites, identified one dietary metabolite. It's called transvaccinic acid, or TVA, to be the one that actually is able to help T cells to differentiate and become good T cells, number one. And number two, when you look at ability of the immune checkpoints to work, this TVA enhances the ability of immune checkpoint to work in tissue culture. And then he tested this in preclinical animal models and was able to confirm the results. So TVA is a dietary metabolite that is derived from beef and dairy. So very interesting. We went on to dissect how TVA affects T cells. So very extensive amount of work. But the important point is what we're now planning is to consider a clinical trial, because TVA, the compound is widely available, as in fact, in some instances over the counter or as part of supplements.
Yeah.
So can we make TVA and use it in two approaches? Number one, as a potential preventive approach, kind of a chemo prevention approach. So we're trying to test that to see whether it can actually prevent development of ovarian cancer. So for example, patients who are at high risk, who carry BRCA1 or BRCA2 mutations or other forms of mutation, could these individuals benefit from a simple strategy such as this nutrient to reduce the risk, the lifetime risk of developing ovarian cancer? So that's one question. The second question is, could we utilize TVA to boost the efficacy of immune checkpoint inhibitors? So those are two clinical trials that will need to be conducted. We're in the process of putting grants together, again, resources and funding and all of those things. So one thing leads to the other. So now that we've discovered TVA, what are we going to do with it? Those are the two things that we are thinking of doing with those very fascinating findings.
Absolutely, and this could be practice changing, and TVA, like you mentioned, in a supplement form for people who possibly don't eat meat or have dairy, but they could take the supplement as TVA for high risk as well as existing ovarian cancer survivors. So that is beyond fascinating. Thank you so much for sharing this with us, Dr. Odunsi. We would love to stay, updated with the progress that these trials make. I would sign up if I were a BRCA positive, but I'm not. But I do have family history, so. But it's just very exciting. So I know we are approaching the top of the hour, but just short answer to yes or no. Do you think immunotherapy one day will cure ovarian cancer?
Yes.
Wonderful. And
but I'm biased, right? So
no,
yes.
no, I actually agree with you in the sense, because I feel like this is attacking the system from an elemental form, and I do have a lot of faith in immunotherapy, actually. I mean, I'm, sharing that with you online. So, and what have I not asked you that you would like to share? I mean, I have asked you a lot of questions. What is it that I've missed?
Thank you, Vax. Pretty much you've covered a lot. But I think maybe one question is, just a message of hope.
Yeah, I'll come to that. I'll
Oh,
come to the
okay.
message of hope. But I
Right.
was just
Okay.
saying, from a science standpoint, is there anything that I've missed asking you?
I think we have covered very extensively. I mean, there are a lot of other nuances that we did not get into. So if you note, I talked a lot about T cells. We did not even touch on NK cells and other cell populations. So there are studies ongoing testing other types of cells for immunotherapy. There's a population of cells within the immune system that are called natural killer cells. The natural killer cells can, just like their name, they can kill tumor cells. So there are ongoing trials. The one that comes to mind the most is trials going on at the University of Minnesota, Dr. Melissa Geller, looking at how to use NK cells, generating NK cells from patients and giving it back to patients, ovarian cancer patients, for therapy. So that's one example of something you haven't asked.
So we'll come, invite you back for a second cup of coffee so that we can get to all of that. And so, in general, last question before I come to the message of hope. So, how do your patients motivate you, Dr. Odunsi, to become a better doctor and researcher?
Oh, I mean, the patients motivate me. They inspire me actually to do what I do. Patients and their families, and this is coming from a place where I have seen the good, the bad, and the ugly regarding ovarian cancer, and it's very distressing, especially as we all know, we form bonds with our patients because the journey can be a long journey, and in fact, they almost become family. And so, so you want to do everything possible um, to help the patient, and so that is a major source of inspiration, and that keeps me going each and every day.
Thank you. And the last question is, as I ask all my episode guests, what message of overcoming would you like to share with our overcomers listening today?
There is hope. I think, let me just put it simply, there is hope because we know more than we ever knew before. I mean, who would have thought 15, 20 years ago that within a few days we can sequence the entire genome of a cancer to understand potential targets, potential drugs that we can use. So that has become routine now, where we can do molecular testing and use that to identify clinical trials or to triage a patient to appropriate forms of therapy. Who would have thought about PARP inhibitors 15, 20 years ago? Maintenance therapy. So we're seeing prolongation of survival, good quality of life. We are seeing all of those things, but the work is not done. There's a lot more to be done. And that's why organizations such as Overcome is so critical to help us to get the message out that there's hope. We now can do a lot of things that we never could have done before. We have a deeper understanding. We talked about some of the different subsets of ovarian cancers. We now know that they're not the same. Therefore, the way we think about treatment is different. We have advances in molecular engineering, advances in drug discovery and development. We talked about the use of oncolytic viruses, the drug factory, different ways of manipulating the immune system. All of those things I think are going to come together to help ovarian cancer patients. So if you're listening, there is hope. And I cannot wait to see that day where this becomes history.
Neither can I. And that's such a fantastic message of hope. And, as you said, there's so much science and so many discoveries, and so many of you working diligently to find that, elusive cure for ovarian cancer. But I do think, along with you, that immunotherapy may be the one which brings about the cure for ovarian cancer. So on that note, thank you so much, Dr. Odunsi, for all your wonderful insights and for sharing your invaluable knowledge with our overcomers today. And overcomers, what a start of the year. What a fantastic episode with Dr. Odunsi. Please share these wonderful insights that the pearls of wisdom that he shared with us, with anyone who may benefit. And let's say hopeful, like Dr. Odunsi said, and I do believe that immunotherapy will be groundbreaking in the near future. So with that, we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.
Thank you.